Mein Name ist Helge Möllmann. Ich darf heute diesem Symposium vorstellen, zusammen mit Professor von Zurmühlen aus Freiburg. Das haben Sie gerade schon gehört. Wir wollen uns aber insgesamt möglichst zurückhalten, weil wir haben unglaublich viele gute Vortragende mit relativ kurzen Vorträgen. Und denen wollen wir gar nicht so viel Zeit wegnehmen, sodass dann unter Umständen auch noch ein bisschen die Möglichkeit zur Diskussion bleibt. Die sollen Sie bitte, liebe Teilnehmerinnen und Teilnehmer, ganz intensiv nutzen, damit wir das ein bisschen interaktiver machen können. Wir werden versuchen, Ihre Fragen entsprechend zu moderieren und möglichst auch zu beantworten. Das gelingt vielleicht nicht immer, aber zumindest wird dadurch die ganze Sache deutlich interaktiver. Damit möchte ich mich schon mal erstmal wieder zurückziehen und an den Co-Vorsitzenden, Professor von Zurmühlen, weitergeben, der dann auch ins richtige Programm gleich starten wird. Konstantin.
Ja, Helge, vielen herzlichen Dank für deine Worte und auch da draußen möchte ich ganz herzlich begrüßen, die Referenten begrüßen, aber natürlich Sie als Zuhörer, Zuschauer ganz herzlich begrüßen. Wir haben einige spannende Stunden vor uns. Und wie Helge Möllmann schon sagte, wir haben so viele Vorträge, dass wir auch ziemlich schnell jetzt einfach starten und mit der Keynote Lecture beginnen. And I have the very special honor to introduce Ricardo Petraco. He is a consultant interventional cardiologist from the Imperial College in London. And indeed, he takes us on a journey through physiology and shows us about the past, present and future of this exciting technology. Ricardo, I hope you're online with us and we are very much looking forward to your talk now.
Many thanks. I hope you can hear me. Very good, excellent. Thank you very much. It's a real honor for me to be here talking to you about the history of physiology. Sometimes when you are asked to give a talk on the history of a topic means that you are old enough to have lived enough through the field. So I'm going to take you through the history of physiology, see what I have sort of experienced over the last decade or so, and perhaps go a bit back further to understand where we are today in terms of the technologies available. So that's the aim of the review. What was available before we're all here, what we live at present, what the change we've seen in the last decades, whether there have been any paradigm shifts in the way we apply physiology, and perhaps what is waiting in the future for us in the cath lab. So most of you will know this, that coronary angiography has been around since the late 50s or early 60s. It was invented by chance or discovered by chance, and not until the late 70s that the PCI was invented. But what is really interesting to know is that the very first percutaneous coronary intervention by Dr. Grunzig was in itself the first ever physiological experiments and clinical measurements in a patient's coronary artery. Very few people know that actually during the first angioplasty, he had a pressure sensor distal to the stenosis, and he therefore performed the first ever coronary physiological measurements. We can't call this FFR because it was a resting pressure gradient, and also we can't really describe it as any comparable to new indices because the technology he had was very obsolete and had large catheters with very little fidelity on his measurement. But nevertheless, the first PCI came together with the first ever physiological measurements. And of course, the technology evolved significantly. And if I just take you through roughly what was done in the very beginning, we had what are called fluid-filled catheters going through patients' stenosis to measure pressure gradients. And in the late 70s and early 80s, there was a sudden interest in measuring coronary flow, with the coronary flow wires being developed and applied. And later on in the 90s, pressure catheters and pressure sensors were invented to what we have today across many different companies and type of sensors, very high fidelity pressure measurement devices. And of course, what we have seen in the last 10 years is also a significant change and improvement in software power, which allow us to make much more precise and sophisticated measurements than before. One thing that we've learned very early is that we knew the concept of ischemia, and we knew that the outcomes and symptoms from patients were coming from reduced flow. And flow became really obvious at the time as the target to reach and to measure, as it was clearly what's driving symptoms in patients with coronary artery disease. But equally, it became very obvious for the first measurements that coronary flow wasn't an easy thing to measure necessarily. We have here papers from the early 70s when the first flow, intracoronary flow was measured in humans, to navigate into the mid 80s when they started studying the reproducibility of coronary flow, and they invented the concept of coronary flow reserve as a way of assessing the coronary circulation. However, it became very obvious very clearly that despite being a very precise biological target, measuring coronary flow was very difficult. And I show you here a relatively contemporary flow trace from a research case. And you can see that it's very difficult to achieve good flow measurements in every single patient. And when you compare to the pressure above, pressure has a much higher signal to noise ratio. So the challenge at the time in the 90s was we knew that flow was the aim to be measured, but we couldn't do it precisely. So it wasn't until the geniuses of Nico Pilz, Lance Gold, and Bernard de Bruyne came together and invented the concept of FFR, which nothing is else than a pressure estimation of a flow reduction in the presence of stenosis. So the big breakthrough in the early 90s was with our ability to estimate flow reduction caused by a lesion, but using pressure, so avoiding the need to directly measure flow. And needless to say that FFR became established as a technique and was the first technology ever to show an improvement of outcomes over angiography. Thousands, hundreds of thousands of papers and studies have documented its benefits, and it was the first direct physiological tool to not only show benefit of angiography, but to enter guidelines. So everything that we have today, we thank to these early inventors of the fracture flow reserve and hyperemic assessments. So in terms of the timeline, we had angiography in the 60s, and not 33 years later, the early development of FFR, which really took more than a decade from then on to be established. However, there was a problem with fractional flow reserve, and this was acknowledged by the leaders in the fields. And there's a very nice editorial here by Professor Pilz in 2011, which states that at the time, the most difficulty step to implement wide use of physiology was maximum hyperemia, and achieving maximum hyperemia in every patient consistently. And there was even a idea at the time that any technique that would not use hyperemia would be incorrect and wrong. And the terminology they used to say was that anything that doesn't follow the fixed cutoff for FFR under hyperemia should not be considered sufficient. And I think those two statements and those two dogmas of fractional flow reserve are the ones that actually prevented it from becoming a wider technique. We have guidelines recommending it from 2014, 2018, they repeated that recommendation. But nevertheless, FFR has always been seen until recently as that tool that will give you a dichotomous information on you should stent or you should not stent. And that approach, although it's easy to teach, not necessarily help more intellectual or interested cardiologists who want to really use the technology in a bit more clever way. And perhaps for that reason, FFR, until very recently, was very poorly used and adopted across the world, with very few exceptions of centers in Europe and America. Adoption internationally was very, very low, which includes the cost of the device itself, but certainly the need to achieve maximum hyperemia in every single measurement in patients with multivessel disease was not very helpful. So if I take you through a little bit of the history of how resting indices came about, in early the 2000s, the concept of what they call the wave intensity analysis, which is a way of assessing how energy is transmitted inside arteries, was developed at Imperial. And Professor Kim Parker with Alan Hughes, led by Justin Davis at the time, described how wave intensity can explain the way that blood flows through the coronaries. And later on, that led to the development of IFR, by identifying what you call the wave-free period in diastole and developing an adenosine-independent index of stenosis severity, which was very challenging at the time because we are challenging the most important dogma of fractional flow reserve, which is the need to give hyperemia to assess a coronary stenosis. And as you can imagine, the journey was at the time quite fast. This is the first ever measurement of IFR. You can see that from the traces, a very tight lesion. And from development to adoption and approval by FDA 2014, we had a quite turbulent journey, as you can appreciate if you remember at the time. The response was positive from a lot of the community, but the leaders in the field didn't believe in what we were doing. They said the IFR wasn't close enough, and they even described as some of the inventions we had as nonsensical. So this is early on the development of IFR. So it's interesting to see how things have changed now. At the time, Professor Serois was very pragmatic and very helpful and said, there is no point you discussing which one is correct and which one is wrong. Let's let the physicians, the clinicians decide whether they trust or not the technique. And that has led to belief and to the development of trials, which really finally demonstrated that the use of IFR, a resting index, was equivalent and non-inferior to fractional flow reserve, which perhaps a few years earlier would be just unacceptable. To the point that other independent physicians started seeing perhaps IFR as a new standard of comparison, and that's the case indeed for now all other resting indices who are coming to be used in clinical practice. So there you go, we have 2017 now, the non-inferiority demonstrated of IFR against FFR in our journey of what's been happening since the development of physiology. What was really fascinating to learn at the time was not only IFR was non-inferior to FFR, but what we have demonstrated with resting physiology is that we could overcome one of the most important limitations of assessing stenosis with hyperemia, which is the crosstalk between lesions. And this slide here summarizes very briefly the reason why FFR is not reliable when you're assessing serious stenosis, because the presence of a lesion would affect the hyperemic flow in the second lesion, and therefore, as soon as you treat it, the FFR of the first lesion will change. Resting indices are under the correction of autoregulation, and you don't suffer from such problem. And therefore, the development of IFR not only helped us to expand the use of physiology, but really transform the way we use physiology, moving from this dichotomous yes or no approach to a much more intelligent use of pullbacks and understanding whether lesions are diffuse or focal, and even more so, allowing us to do what is called the planning of a PCI before we put a stent. This is a co-registration screen that you can see here that you can get with IFR, where you describe and you display your IFR values across the angiographic arm. And this is really important, this concept. You can only use this reliably if you're using a resting physiological index, because we are avoiding here the crosstalk between these serial lesions. So not only resting physiology came to show that perhaps hyperemia wasn't needed in all cases, but there was an advantage, a biological advantage, which is the assessment of serious stenosis. And we have all learned that, implemented it in our clinical practice these days. So IFR pullback and IFR co-registration. Another consequence of the development of resting IFR at the time was the ability of us understanding that in a lot of patients, we started noticing that we were leaving stenosis after PCI, and this is a result of the FIND PCI presented last year, showing that in a significant proportion of patients, there was residual ischemia, although we can debate whether ischemia here has a necessary fixed description. But in about 80% of such residual ischemia, the lesion was focal. So by just using physiology and not using necessarily a pullback with identification of serial lesions, we were missing within a vessel where to stent. And this is not perhaps surprising, because if we learn from FFR that we can't tell which vessel we should stent, we certainly should not know which segment of the vessel to stent without using physiology as well. And more recently, the FIND PCI also showed that residual ischemia has repercussions in terms of outcomes, with a significant difference in MACE, and importantly, significant difference in hard events like mortality when vessels are left with residual ischemia. Whether this is something we can address during PCI is still to be answered, but observationally, we can tell that the findings of physiological post-PCI are very, very important. And of course, because of all these information accumulated over the last decade or so, initially, IFR was presented as a mid-diastolic index based on wave intensity analysis, and we were challenging the dogma of hyperemia. And although early criticism came to sort of debate our approach, Professor Seroy's conclusion that we should wait and see what physicians would say was very correct, to the point that now many other companies and many other institutions are developing their own resting indices. There is one thing that is common across all of them, is that they're all diastolic and they're all phasic. None of the new indices are now using whole cycle physiology. They are all one way or another identifying periods in diastole to make physiological measurements. And therefore, we can actually say that our group here took the hits initially on this walk through Koronarphysiology, and now that we have shown that hyperemia is not necessarily needed in all cases, of course, we welcome all the other indices if they're coming to expand the use of physiology wider in cath labs around the world. Now, this is just a point perhaps to understand why things are very different these days. This is the early studies which validated FFR, and you can see here that from the very obviously early types of catheters, which were fluid-filled catheters, much bigger than they are these days, the pressure sensor that used to get distally, the pressure waveform, was very damped, and you couldn't at all describe systole and diastole within the cardiac cycle. And therefore, the only way of calculating any ratio at the time was by using whole cycle, and therefore really hyperemia was essential. Whereas all indices today are using much more modern technology, but more importantly, much more advanced software, which are able to identify in every cardiac beat the best time in diastole to make measurements. And that's not surprising, because that's where its flow is the highest and resistance is the lowest. So, in bottom line of all the new resting physiology indices which are coming out, they are very similar to IFR, perhaps because they are only a few milliseconds away or different from the original wave-free window which was initially described. The other very important point about the pullback, co-registration, and the new indices is that we have learned that instead of the old dichotomous approach to above and below 0.8 cutoffs of intervention, we are using physiology now in a much more intelligent way. We are doing full vessel assessments and not only deciding yes or no to stent a lesion, but using a number to certainly make a decision on how bad the ischemia is, and using it as a quantifiable way of making decisions in the cath lab. So now what we have is, from the angiography on the 60s to hyperemic indices in the 90s, up to early introduction of IFR a decade ago. And nowadays we have a multitude of resting indices which enable us to perform much faster physiological measurements in multivessel disease, particularly with the benefit of advancing a serial lesion assessment and within vessel ischemia. So what the future holds for physiology, I think very obviously we are very rapidly moving from the view of physiology or not stenting to a much more intelligent application of methods and decision-making within the vessel. This is something that is already seen, and we're going to see more and more. And the prediction is that in 5 years' time, all the new generation of cardiologists being trained will not make decisions based on angiography, even where to stent, and certainly not how to stent. The other exciting field, which I don't have much time to talk about, but which needs a lot of improvement, is the using modeling on angiography to predict physiology. We have the most established technique called the QFR, but other methods are being developed out there. There is still a lot of work to be done there, and although they are exciting in terms of the ability to predict within a vessel where most of the pressure drop is occurring, there is still not matching current physiological values good enough to be used widely. And finally, we have a very new interest in the microcirculation and patients with angina and no obstructive coronary artery disease, and many new technologies are coming as well, which help us guide therapy for these patients. And finally, a talk that I'm going to deliver later on today, the use of artificial intelligence in cardiology. It's a reality in all imaging and specialties, and will certainly be the case in the cath lab. And I hope we'll discuss this more later in details. Thank you very much for your time, and I'm aware I'm already over it.
All right. Dear Ricardo, thank you very much for taking us on your journey through physiology. Very exciting history that you showed us today. And we already have a question from the audience, which I would like to address to you. There's a question: what do you think about measuring with side hole catheters in IFR and FFR? So a more general question, but I think a very important question for the daily use of the technology.
A very important question indeed. And the recommendation for any type of physiological measurement, being FFR, IFR, or any other index that you are using, is not to use side holes, for a very simple reason that I'm going to address later in my second talk on use of artificial intelligence. But is the point that you can't rely on your proximal pressure waveform to make measurements. And the side hole catheter will be giving you misguidance on the waveform, and maybe your catheter could be well in the middle of the LAD, blocking flow, and you're still going to have a nice proximal pressure waveform, which will be misleading. So the short answer is, for reliable physiological measurements, we should not be using side hole catheters for physiological assessment.
Okay, that's a very clear point that you made there. When I look at your slides and I see the development of indices and especially of cutoffs, and when I look at the new data from Define P,
It's very important for people to understand that these are observational data. So these are data coming from observed findings after PCI. And the debate here is whether residual ischemia is a sign of ischemia within your stent that you should do something about, or whether it's just a sign overall larger plaque burden. And I think we won't be able to answer this question until we specifically have studies documenting on whether you should do something about residual ischemia. The target FFR also presented in TCT showed that there's not much point you chasing small numbers, but it was still a trial with limitations. The short answer I give in terms of practicality is, if you have residual ischemia after a PCI, make sure that the residual ischemia is not coming from a poor PCI, and the pullback post-PCI should tell you whether the residual ischemia is happening within your stent. And if that's the case, of course, you should try to optimize it by post-dilatation and covering all the lesion necessary. But if the residual part is diffuse loss across a long segment of disease, then you're dealing with diffuse atheroma, and the fact that they have more events is perhaps just natural history of the disease.
Yes, I think this is a very important point. Okay, Helge, do you have any other questions at the moment?
Yeah, I do actually. So if we go back one step further, the decision-making of whether to intervene or not, do you think there's still this clear-cut point where you say yes or no? You have this nice image coming from very deep red to green, and this implicates a little bit there is no clear cutoff point anymore. So it's more a little bit decision-making, but not with one value, which gives us a clear hint. What do you think about that?
I think it's an excellent point, and people have to remember why cut points were ever invented. Cut points come from original studies when they have to find one to describe a best cut point for the modality, and come from ROC curves. And finally, they have to be implemented in trials. In a clinical trial, we have to have cut points because otherwise physicians will deviate from protocols. And of course, they finally are implemented in guidelines based on those trials. But biologically, there's no reason to think that an FFR of 0.79 is different from a 0.81, and an IFR of 0.91 is different from an IFR of 0.88. So really, the new and clever use of physiology is by not ignoring cut points, but by using them together with the information of how those pressure losses occurring across the vessel, and make your decision together. I often defer LADs of 0.77, 0.78 if the loss is diffuse, and I sometimes stent focal lesions in the OM when the FFR is 0.82, for example. So we have to look at it in a more gray zone way rather than black and white, but only with a pullback capacity we are able to do that. And this is really important. The way we do physiology is changing because we are able to see within a vessel where the pressure loss is occurring.
I think this point, Ricardo, is very, very important for the everyday practice, because a lot of physicians think that they are only believer if they decide with this one cut point. And probably the better way to go is the pull back and make a decision based on the value, but not purely based on the value, more the overall clinical image. And I think this is very important to bring both parts together.
I have another question from the audience. I think it relates to the first question that I asked you with the side hole catheter. The question is, what do you think about disengaging the catheter from the ostium before the measurement, if you use side hole catheters, I assume?
So if you're confident you can do that, that is not a problem. As I said, the problem of the side hole catheter is that it can falsely give you a number when the tip of your catheter could be blocking flow into the vessel. So it could be falsely reassured that you are in a good position. Now, if you are very pedantic and you follow your steps very correctly, and you make sure your guide is well within the aorta, then it doesn't really matter whether they have holes or not in the catheter. And a lot of the time we'll be doing assessment with body wires to ensure that, particularly when you have osteo lesions, to ensure that both your normalization and your physiological measurements are happening outside when your guide is in the aorta. So if that's the case, then it's absolutely fine.
There are two practical questions left. One is, what about using a 5 French guiding catheter for the FFR measurement? And the other one, perhaps you can answer it together. What is your strategy in IFR with nitro? How much and at which step exactly do you give it?
Two good questions. I don't have a major problem with FFR in the 5 French catheters, providing that you ensure that your catheter is well flushed and there's no contrast or full of blood, which can dump the signal. And particularly if you're not doing measurements, obviously, with balloons and other things inside it to even make the signal more dump. So 5 French catheters, in theory, should not be a problem to make measurements, providing they are guides and not diagnostic catheters, which we also recommend not to use. Now, the second question was on...
Second question was about
nitrates. Very good. So I see nitrates in the same way as I give heparin. I tell my fellows that I don't have to ask them to give nitrates, and we give at least 300 milligrams, unless the blood pressure is very, very worrying low. I give 300 milligrams across, and if the blood pressure is normal, I very often give like up to 1 milligram of nitrates. And what I do is every time I do an ACT to check a heparin, I remind myself that maybe is a time to top up the nitrates. And you can see that every time you do that, you get residual change in your physiology. So for any type of physiological measurement, being IFR, FFR, or any microvascular assessments, you should have given nitrates to stabilize your epicardial vessels.
All right, so I think these are our questions for the moment. And Ricardo, thank you very much for your excellent talk, for your interesting journey, and especially thank you for answering the questions in a very practical manner. I think we can move on, if there are no further questions, towards the breakout sessions. And maybe I then switch back to German and say goodbye to Ricardo Petraco, goodbye to London, and stay healthy.
Thank you very much. Thank you for having me. It was very, very good to join you.
Thank you very much for having you. All right.